Hey guys, so I'm still trying to figure out how to record and stuff. I need to get me a little mic. I'm gonna invest in that, put on my t-shirt because this audio, I want to make sure I get it recorded, not like my other two videos I did. Um, my friend just texted me and she said you need to buy you one of those microphones, the ones that you be using for the podcast. Definitely gonna invest in that. Jessica, you read my mind. I'm gonna invest in that because there's this echo, but as I'm videotaping myself, I notice one of the side of my face is droopy. I probably had a seizure back then and I didn't even know. Okay, so let's get real. Um, so I'm gonna move on. I'm uploading my video on Fintioin. It's taking forever. I don't know what's going on, but I'm gonna go ahead and start with this next. We're moving on. I was gonna do the next medication, but I need to focus on neurological right now. Chapter 63. It is on the exam for Tuesday, exam 2 for the nursing second semester program I'm in. So what I'm going to do now. I'm just gonna read my notes that I took from class, and I have my book I'm following along in, and gonna try to mix that up. And so I can't see myself on videotaping because my notes are on my laptop. So if I hopefully don't get out of frame, um, and you can still see me for those of you that want to see me. I don't have any makeup on, as you can see. I am doing no makeup. Anyways, okay, so let's start. Chapter 63, Neurological Problems, Med Surg. This was a lecture from January 31st. And nursing program, yeah, we're on February 11th, and we're barely going to have an exam on it. That's how it works. All right, nursing management for chronic neurological problems. You have headaches, seizures, seizure disorders and epilepsy, multiple sclerosis, Parkinson's disease, myasthenia gravis, amyotrophic lateral sclerosis. And I will say my notes, like I try to type as fast as I can, so if I miss something, I apologize. Headache. We need to know primary versus secondary headache. We need to know the difference. So I'm going to look at my book on headaches. It is the most common type of pain. Most people have functional headaches, such as migraine or tension type headaches. So I'm trying to find the difference between primary and secondary. Let's see what it says. I see tension type headache, migraine headache, cluster headache, other headache. Is there like a list of headaches? Which one's primary and which one's secondary? Okay, here we go. Primary headaches include tension type, migraine, and cluster headaches. They are not caused by a disease or medical problem. So think of primary, they are not caused by a disease or medical problem. Secondary are caused by another disease or problem, such as a sinus infection, neck injury, or brain tumor. Okay. A patient may have more than one type of headache. The history and neurological assessment are key to deciding the type of headache. Neurological assessment and the history, remember that. The assessment is often normal. Unexplained, abnormal findings may require further diagnostic studies. So, reading back on my notes, it says classification from the International Headache Society diagnostic criteria. Let's see, what does it say? I didn't write it down, so let me see. Information from the headache. What? From the Headache International Headache Society diagnostic criteria. I don't write nothing else on it. I'm trying to see where my teacher got that information from. I know it's from the book, but I guess if I see it along the way, I'll put that back in here. But that's all I wrote down. So we have tension type, migraine, cluster. Patients have more than one type of headache, so there's different types of headaches. Headache is probably the most common type of pain experienced by humans. I've never really had headaches. Growing up, I didn't. And then I started experiencing migraines. I didn't believe in headaches. I thought people just made that up, but it's real. Pain location for common headache syndromes: tension, migraine, cluster. You need to know the pain location. Clusters focus in and around one eye. Let me go back and read that because I didn't write that down. Well, actually, let me go back and say what kind of each headache is. So, and the location, because we need to know the location. All right, so tension type headaches. The location is bilateral, band like pressure at the base of the skull. A migraine headache is unilateral, and it is in 60%, unilateral in 60%, may switch sides, often interior location. Cluster headaches are unilateral, radiating up and down from one eye. Cluster headache. The tension type, maybe I should go through each, like one and then everything. Tension type headaches are bilateral again. They start at the base of the skull. They are constant squeezing and tightness, a tension, tight tension, think. And then they are frequency cycles for many years. Duration, it's usually 30 minutes to 7 days. Oof. And it is time and mode of onset is not related to a time. Associated symptoms would be palpable neck and shoulder muscle tension, a stiff neck, and tenderness. Treatment for this would be abortive and symptomatic drugs, non opioid analgesic, aspirin, acetaminophen, NSAIDs, analgesic combinations, butalbital, acetaminophen, caffeine, and butyl aspirin, caffeine, and muscle relaxants. So this is just for tension type headaches. And it's also known as a stress headache. Then I probably have been plenty of those in my time. It is the most common type of headache. And migraine headaches, let's see. It is a reoccurring headache categorized by unilateral throbbing pain. Migraines are most common between the ages of 25 and 55. 1 in 4 U.S. households have someone with migraines. Wow. We do not know the exact cause of migraines, but they likely result from complex interactions between trigeminal neuron, vascular, genetic, hormonal, and environmental factors causing vasodilation and inflammation in the brain. Current theories suggest a complex series of neurovascular events starts the headache. Okay. Migraines are related to many disorders. These include seizure disorder, ischemic stroke, asthma, depression, anxiety, hypertension, and IBS. So I probably had a migraine too because I have asthma, depression, anxiety, and IBS. Okay, in many cases, migraines have no known precipitating events. Other risk factors include age, female gender, of course, obesity, low education level, and stressful life events. I've had plenty of those. Okay, let me go back and read the list. So it is a throbbing, synchronous with pulse, periodic cycles. The frequency is periodic cycles of several months and years. The duration is 4 to 72 hours for migraine. Yeah, I'm sure I've had that. The time set may be preceded by prodromal symptoms or your aura. Onset from awakening improves with sleep. So get some rest if you have a migraine. The aura is like visual, sensory, aphasic, irritability. These are associated symptoms. Vomiting, sweating, nausea, photophobia, phonophobia. Prodromal symptoms would be sensory, motor, or physic or psychic pneumonia. Okay. Treatment for this, there's a list. Wow. Adrenergic blockers, ergotamine, dihydrogotamine, NSAIDs, serotonin receptor agonist, almotriptan, L-triptan, All these that end with PTAN. I can't say them. I'm not going to say them all. A combination would be acetaminophen, caffeine, aspirin, sumatriptan, naproxen, and CGRP antagonists like lambda-cyhalothrin. Okay. Next would be cluster headaches. They are unilateral, radiating up from and down from one eye. Severe bone crushing. They have the frequency may have months or years between attacks. The attacks occur in clusters over a period of 2 to 12 weeks. Wow. Its duration is 5 minutes to 3 hours. And they are nocturnal, often awakes person from sleep. Facial flushing or pallor, unilateral lacrimation, ptosis, rhinitis. These are associated symptoms, and treatment would be adrenergic blocker, serotonin receptor agonist, and anything ending with PTAN. Well, I won't say anything, but these drugs that end in PTAN and TRIPTAN, and high flow 100% oxygen. Let me read about a cluster headache. It is the most severe form of a primary headache. Wow. So again, what was the difference between primary and secondary headaches? Primary, I'm not sure. Let me read. It includes tension type, migraine, and cluster. They are not caused by a disease or medical problem. Cluster headaches are not caused by a medical problem. Secondary are caused by another disease or problem, such as sinus infection, neck injury, or brain tumor, so that leads to secondary headaches. And what else does it say? Sorry. Cluster headaches is classified as a trigeminal autonomic cephalgia. It affects the trigeminal nerve, cranial nerve 5, and has associated autonomic symptoms such as tears and a stuffy nose. Age at onset is often 20 to 50 years, but they can start at any age. They are more often affect persons who smoke and men. You know, I'm starting to think, I wonder if my son has had some headaches because he does sometimes get tears in his eyes. Like, I thought it was because he don't wear his glasses, but he does complain about headaches. Like, We do not know the cause or how cluster headaches occur. Imaging studies show activation of the hypothalamus and trigeminal vascular complex at the onset. So again, we need to know the primary difference between primary and secondary headaches. I'm just continuing to read. So we need to know the location for common headache syndromes, for tension, migraine, and cluster. And we said the tension is bilateral band-like pressure at base of skull. The migraine is unilateral and 60% may switch sides, often anterior location. And the cluster headache is unilateral, radiating up or down from one eye. That's the cluster. All right, patients are encouraged to keep a diary. All right, headache, tension type. Oh, so now she breaks it into each one. I kind of went over this, but I'm going to go over it again anyways. Hold on a second. I want to see if my other video has finished uploading. Ooh, almost 9 minutes left. Okay, make sure you watch that one on phenotype. Anyways, quit getting distracted. Let me go back to my notes. All right, so starting with headache tension type, the patho. It is the most common type of headache, also called stress headache. It is categorized by bilateral constant squeezing, tightness, pressure around the head. Episodic or chronic, it lasts for minutes to days. No nausea or vomiting involved. May involve insensitivity to light, phototopia, or sound, phonophobia. I didn't know what that was. Okay. Diagnostics would be patient's history and electromyography. Headache, the migraine, the physiology, exact causes unknown for migraines. And it is a strong family history. I guess, oh wow, that's sad if it runs in the family, huh? Recurring headaches characterized by throbbing pain. Matching pulse. Headache may last 4 to 72 hours for a migraine. Not all are disabling during headaches. Some patients hibernate, seek shelter from noise, light, odors, people, and problems. And they have migraines. They rest in a dark, quiet area is recommended. Affects females more than males, of course. Headaches, cluster, etiology, and patho. Neither cause nor pathomechanism is known for cluster. Rare form, one of the most severe forms of head pain is cluster. That sucks. Repeated headaches that occur for weeks or months at a time with remission. It is a sharp, stabbing pain and typically lasts between minutes to 3 hours, usually located around the eye. The triggers would be alcohol, strong odors, and napping. Wow. Client is usually agitated, and restless. Diagnostic studies include a CT scan, MRI, or MRA. Acute treatment would be inhalation of high flow, 100% oxygen at 7 to 12 liters minute for 20 per minute for 20 minutes. All right, headache. Nursing management. How you want to manage these headaches. Implement what? An inability to cope with daily stresses can cause headaches. So, cope. Learn how to cope with that daily stress. That's tough. Examine their lifestyle, recognize stressful situations, and learn to cope more appropriately. Daily exercise, relaxation periods, and socializing help reduce recurrence and should be encouraged. Suggests alternative pain management such as relaxation, meditation, yoga, and self hypnosis. Okay, suggest alternate. Y'all, I'm getting distracted. I'm really thinking about that microphone I need to order on Amazon. Okay. Suggest alternative pain management such as relaxation, meditation, yoga, and self hypnosis. Encourage a quiet, dim environment. Manage. I'm sorry. Massage and heat packs can help with tension type headaches. Yeah, for real. I believe that. Because whenever anyways, let me just stop. Patients should have a written note of medication to prevent accidental overdose. Okay, so next we're moving on to seizure disorders, but let me flip through my book to see, make sure anything else. I'm reading right here on comparison of headaches, the tension type, migraine, and cluster. So preventive treatment would be anti-seizure drugs for tension, Topamax, Depakote, adrenergic blockers, botulinum toxin A, muscle relaxation training, Prozac, Paxil, give me some of that Prozac, tricyclic antidepressants. For migraine headaches would be anti-seizure drugs, adrenergic blockers, botulinum toxin A, CGRP antagonists, tricyclic antidepressants. Cluster headaches treatment and prevention would be adrenergic blockers, ergotamine tartrate, anti-seizure drugs, gabapentin, topiramate, corticosteroids, CGRP antagonists, and lithium. I'm going to highlight the ones that they're each in, well, they're not in each one, but adrenergic blockers are one that each one of them have. Well, B and A. And botulinum toxin A is in migraine and tension type. I need to figure out what that is. Headaches. Remember, in men, cluster headaches are 37 times more common, have more exercise-induced headaches. Women, migraine headaches are 3 times more common, have more tension type headache. Here, interprofessional care for headaches. We need the diagnostic assessment would be a history and physical assessment, neurological assessment, inspect for local infection, palpate head for tenderness, bony swellings, auscultate for bruits over major arteries, especially neck. Lab studies would be CBC, electrolyte analysis. Diagnostic would be angiography, CT scan, MRI, MRA, EEG, and an LP. Management with drug therapy, biofeedback, cognitive behavioral therapy, relaxation therapy, and sleep modification therapy. So a whole lot of therapy. Let's see. Clinical problems for the patient with headaches may include pain, deficient knowledge. Additional information on clinical problems and intervention is presented in the book for the patient with headaches. Planning. The overall goals are that the patient with headache will have reduced or no pain. Understand triggering events and treatments, using positive coping strategies to deal with the pain, and have increased quality of life and decreased disability. Now, again, we want to ask the patient to keep a diary of headaches with specific details, okay? This can help identify the type of headache and precipitating events. Avoid diet triggers is helpful for most patients with cluster and migraine headache. If there is a history of primary headache, ask if the character, intensity, or location of the headache has changed. The answer may be an important clue about the cause of the headache. I know it causes me headaches. Anyways, okay, I hope this was a good overview on headaches, the different types. Remember, we need to know the difference between primary and secondary. I think I'm going to end this video and then proceed with the seizure disorder in the next video. Let me see if there's anything down here that talks about headaches anymore. I don't think so. So I'm going to do that. I'm going to end the video here and then proceed with seizures. And again, this is the neurological system, okay?